And move on for our next speaker, our Marlies Ostermann, and she's going to talk about quality of life after AKI.
Ladies and gentlemen, good morning. It's a great honor to address a very important topic at this exciting conference. And in the next 15 minutes, I will talk about quality of life, which I'm sure you agree is an important outcome for everybody, in particular patients with acute kidney injury. And I will highlight that there are still a lot of gaps in our knowledge and there's a lot of work to do. Here are some disclosures, but they've not affected what I'm going to say. Throughout the meeting in the last few days, we've all clearly understood that acute kidney injury is a complex syndrome with major short and long-term complications. We've also learned it's a continuum. It affects anybody, from a 1-year-old to an older person. And throughout this, I'm sure you agree with me, there is a risk that quality of life is affected in many ways. But the quality of life of AKI patients not only depends on acute kidney injury, it's also impacted by so many other factors, additional comorbidities, socio-cultural factors, and where we live and the way and how we're being looked after by the team. And then lastly, the data depend on how we assess quality of life, when, tools, and in what manner. So I show you the existing data with the emphasis on there's a lot of data missing and we need to do more in this area. But I want to set the scene and say quality of life is defined as the extent to which one's usual or expected physical, emotional, or social well-being is affected by a medical condition or its treatment. It's clearly personal. It clearly can change. And two people with the same disease and the same treatment may have a very different perception of their quality of life. It's individual and personal. And now I'll show you what we've got in the literature. We have data here from Javier Neira, who will also speak after me. And he looked at quality of life in ICU survivors who attended an ICU follow-up clinic. And as you can see here, of these 104 patients who got analyzed, he divided them into patients with either no AKI or very mild AKI. They got lumped together, compared to patients with moderate or severe acute kidney injury. And they were assessed at 3 months with regards to quality of life and functional status. And the first thing to say here is that patients who had severe acute kidney injury had reduced functional capacity, so their 6-minute walk distance was reduced. They also reported lower quality of life, and with regards to cognition and emotional well-being, there were no differences between these two groups. But the first hint that severe AKI affects people 3 months down the line. And even if it only affects functional ability, the ability to walk and how far you can walk may impact what you can do and your quality of life. And this study prompted a few of us to look at this in more detail. And if you look at the literature, it's very complex, but also confusing because people have reported different data, but also used different tools to assess quality of life. They've done the assessments at different time points, at 28 days, 3 months, 6 months, and 1 year. Furthermore, the responses vary whether you ask a patient or whether you ask a surrogate. And the surrogate may be the parent, it may be the carer, or it may, or in case of children, or it may be carer in case of vulnerable adults. There's also in the literature clear overlap between degree of frailty and degree of quality of life. And they clearly go hand in hand, but can also be difficult to tease out. And with regards to children, there are interesting data in that if you ask children and how they feel and how they're doing, and compare this with how the parents assess their quality of life, it's not always concordant. And again, this makes the literature difficult and the data difficult to analyze. But this review of the literature essentially concluded that in adults and in AKI survivors, there were more deficits in physical than mental health domains, on average, compared to children where AKI survivors, pediatric AKI survivors, reported more memory and learning problems, which obviously also affected quality of life, not only of the child, but the whole family and their social setting. And following on from this, I just want to show you what we know from children in particular. We have data here from Aisha Aksan Arikan, who looked at 203 children who had undergone cardiac surgery during their first year of life. And these children underwent quite detailed, complex neurodevelopmental testing. As you can see here, of these children, 30%, 1 in 3, had AKI, and some of them had recurrent episodes of AKI. And in this detailed analysis, they showed that patients who had 1 or 2 episodes of AKI, so on your right-hand side, on the x-axis, you have the episodes of AKI, they clearly had impairment of their overall development, whether they looked at cognition, language development, or motor development. And this undoubtedly will develop their overall development, and it will also affect the well-being of the family. Although in this particular study, they didn't look at quality of life. They just set out the neurodevelopmental development. The same team looked at other outcomes, and this time focused on patients who had received renal replacement therapy in the pediatric ICU, so severe acute kidney injury. And they were interested in their functional status and degrees of comorbidities, and tried to compare this with their overall baseline status as determined by the parents. And when you do this, you can clearly see this is a dynamic process. It changes a bit, it fluctuates, and there were some children who had very good functional status to start with, had poor status when they left the ICU, but had recovered by the time they left hospital. Similarly, there were children who really left hospital with a very poor functional status. And overall, in this assessment and this analysis, more than 50% of children needed outpatient rehabilitation to improve their functional status. And the team concluded that children who needed renal replacement therapy during their childhood were a group of patients who were particularly vulnerable and needed attention in the following years, not only to improve their development, but also improve their overall quality of life. Now, when it comes to direct quality of life assessments in children, we only have data from 2 studies, and they're only really indirect secondary analysis. We have a retrospective analysis of a database from Seattle with data of children who were in the hospital now 10 years ago. And they retrospectively looked at the quality of life assessments. And I understand in this children's hospital, it is routine to ask, to assess quality of life. So they analyzed the children for whom they had at least one quality of life survey in the database. They used routinely in their clinical practice the appropriate quality of life assessment for children as according to age. And essentially these groups of patients with either no AKI or mild AKI compared to severe AKI, as you see on the bottom here, they were very similar, apart from the fact that children with severe AKI had a higher need for renal replacement therapy. But apart from that, they were very similar. And the analysis of using routinely available quality of life assessment showed that they had been filled out by different people, often by proxies, often the parents, but not always the parents. They showed that these were children, so children with AKI, had important comorbidities affecting their long-term well-being. Now, there were no differences in quality of life at baseline between children with mild and severe AKI. But 8 weeks after discharge, the children who had severe AKI had significant physical and emotional impairments, certainly compared to children who had not had AKI. And they were less likely to return to their baseline functional status. And the second set of data with regards to quality of life in children stems from a secondary analysis of the LAB study with data from 12 PICUs in the US. And these were children, the LAB study included children who had community-acquired septic shock requiring vasopressor support. And in this secondary analysis, they showed, as shown you at the bottom, that children who had moderate or severe AKI had lower quality of life at 28 days and also at 3 months. At 3 months, they also had new comorbidities, which they hadn't had before they had come into hospital. And again, these were major comorbidities, again, affected well-being, education, and quality of life. And so this secondary analysis concluded that children with septic shock complicated with severe acute kidney injury were 2.5 times more likely to have a serious deterioration in their quality of life. Now, finally, at the end of this talk, I've shown you the data, I've shown you it's really quite sparse, but the question is there anything we can do? Now, ideally, we would like to avoid AKI. That may make a difference, but is there anything you could do once AKI has occurred? And this has been addressed in some studies, again, in a very random manner. There are 5 trials looking at improvement of quality of life after AKI, and they were summarized in this systematic review. But ultimately, all these various interventions that had been tried did not affect quality of life. They reduced the symptom of post-traumatic stress, but they did not change quality of life in these adult patients. And there's one more study which I also like to point out. It was a study which was subsequently published where they looked at the role of intensive exercise after AKI. And again, this made no difference. It improved their motor function, but it made no difference to quality of life after AKI at 3, 6, or 12 months. The fact that the children or adults could walk faster or longer didn't impact their well-being. So this is where we are. The data on quality of life after AKI are extremely limited. I've shown you what we've got. From what we can see, it appears that AKI does impact quality of life, but the data are so confounded by frailty, other comorbidities, and who fills in the questionnaires. And I put it to you, it's our duty to look at this in much more detail, especially now, one day after World Kidney Day. Thank you for your attention.